Hello and welcome to this learning module. In this lecture, we'll take a deeper dive into the EMS provider's role at large-scale and mass casualty incidents. We're also going to introduce you to some nationally recognized mass casualty triage protocols that are designed to simplify the triage process, enable us as rescuers to do the greatest good for the greatest number of victims at any type of an incident. Upon successful completion of this learning module, students will be better able to, number one, identify the EMS responders' roles at a mass casualty incident, or MCI. Number two, compare and contrast the START and SALT triage systems. And number three, establish and coordinate the triage, treatment, and transport groups of a mass casualty incident. So command is typically going to be assumed by the most experienced and senior member of the first arriving emergency service to the scene. If that happens to be you and your partner on an ambulance, then whoever the most senior EMT or paramedic is on the ambulance is going to assume incident command. Now, it's important to understand that once additional personnel arrive on scene, there may be EMS supervisors, fire personnel, law enforcement, who, based on the type of call, will assume incident command to free up the medical resources to focus on patient care. So, generally speaking, EMT1 is going to assume command. They're going to call in to dispatch with an initial size up of the situation, request additional resources, and let incoming agencies and responders know where the incident command post is located, which is going to be the first arriving ambulance. EMT number two is going to count very quickly or estimate the number of patients so that additional resources can get en route. And they're going to categorize and sort patients by their medical priority, called triage. So this slide depicts the basic incident command structure for an EMS operation. The EMS branch director generally oversees triage, treatment, and transport groups, and if necessary can assign a group supervisor to each group. The triage unit is going to be responsible for evaluating and prioritizing all patients based on a certain criteria. The treatment unit is going to be responsible for patient care at the incident, and then the transportation unit coordinates the movement of patients to appropriate receiving facilities. A staging area may be established, and that's where all of our resources are going to go and stand by until they're requested to move into the incident site. In most large incidents, patients who are deceased are going to be left where they're found because there's going to be investigations that need to take place, whether it's local law enforcement or whether it's regulatory agencies like the National Highway Transportation Safety Administration, Federal Aviation Administration, etc. So we leave the deceased where they are found. All right, so the triage area is going to encompass the entire incident scene. So wherever there are patients located, that's going to be considered the triage area. Once those patients are triaged and prioritized, they are moved based on their priority into the treatment area, also known as the casualty collection point. The priorities that we need to be aware of are red tag patients, which are immediate patients with life-threatening conditions, yellow tag patients, which are patients who need emergency medical care, but they're not hemodynamically stable, so their treatment can be delayed at this point. And then our minimal, which are usually our ambulatory patients with very minor injuries who can either take care of themselves and can be moved to an area away from the incident so we can focus on the actual more critically injured patients. And then we also have a gray category called expectant, and these are the patients who, without additional resources, we don't have the manpower to provide treatment, and they will probably die as a result of their injuries. Okay? And once patients are moved to the treatment area and stabilized, then they're going to be moved to the transport area where they are going to be taken to a facility based on whether it's ground or air, whether medevaced, based upon what their priority is and based upon what the best receiving facility is for their situation. So that is an overflow of how our patients are going to flow through the different areas of triage, treatment, and transport at a mass casualty incident. So triage responsibilities include rapid assessment and classification of patient priority. We talked about the four categories: immediate, which is red; delayed, which is yellow; minimal, which is green; and then gray, which is expectant. Patients who are actually deceased, dead on arrival, deceased on scene. There's also a fifth category that's a black tag. And again, remember that those patients are going to be left where they're found for investigative purposes. Now, it's important to understand that these standardized triage systems are used to quickly sort patients into categories. So this is going to require us to think a little bit differently than we would normally when it's you and your partner responding to a medical emergency in somebody's residence. So if we arrived on the scene of a call at somebody's house, we found somebody in cardiac arrest, we would have the personnel available on scene to initiate CPR, to defibrillate, to start an IV if paramedics are there, and to give medications and to work that code effectively. Unfortunately, we have to remember that when it comes to a large-scale incident with multiple patients, okay, these are usually trauma cardiac arrests, and committing 2 EMTs, 2 paramedics to work a code on a trauma arrest when we've got multiple patients needing assistance, it's just not feasible to do that, because our goal at a large-scale incident or an MCI is to do the greatest good for the largest number of patients. So this requires us to operate a little bit differently. And we've got a couple of different triage systems that are out there and methods to do triage to help us prioritize these patients quickly. So what we're seeing here on this slide is different triage priority identification. You'll notice it's got the same colors: red immediate, yellow delayed, green minor, black deceased, and then what we don't see here are gray, which are expected. So image 1 on the left are actual triage cards that can be flipped around to put their triage priority facing forward, so that those who are coming in to move the patients from the triage area to the treatment area know who our highest priority patients are. Image number 2 shows a triage bag that just has 4 different colors of tape, and basically the responder who's doing triage is going to get in there, tear off a piece of that tape, wrap it around the patient's wrist, and it helps to quickly identify them so that they can be moved to treatment more quickly and start receiving their treatment there. The tag on the right is an actual manufacturer triage tag. There's a lot of different manufacturers out there who have these, so your agency may pick a provider for these that works best with their particular system. And these have tracking numbers that are decals or that can be torn off at perforations, and that tracks the patient as they go through the triage, treatment, transport areas, and continue to be tracked at the receiving facility as well. So the triage tags may be used on site to triage patients, or they may be used to document patient care once the patient is moved into the treatment area. So we've got 3 different recognized triage systems: START, which stands for Simple Triage and Rapid Transport; Jumpstart, which is a pediatric version of START; and then the SORT, Assess, Life-Saving Interventions, and Treatment and Transport, or SALT triage system. So START originated back in 1983 out on the West Coast in Orange County, California. Jumpstart was developed in 1995 by Dr. Lou Romig from the Miami Children's Hospital as a better way to triage pediatric patients, and it builds on the concept of the START triage system. Lastly, the SALT triage is the most recent system. It was created by a work group from the CDC back in 2008 who were tasked with developing a standardized evidence-based triage program. And please note that this program has been endorsed by the American College of Emergency Physicians as well as the American Colleges of Surgeons. So each of these is an initial triage system. It's important to understand that this is just a quick, down and dirty way to sort and triage our patients based on priority so that they can be moved based on their priority to the treatment area and receive treatment for those who need emergency life-saving treatment first. Patients will be re-triaged in the treatment area. They will be re-triaged in the transport area. They will be re-triaged by the EMS crew who's doing the transport, and they will be re-triaged as soon as they receive the receiving, or they are received at the receiving facility or the emergency department. And their priority can be changed as needed according to your protocols. So what we have here is the very first system that was developed back in the early 1980s. It's called Simple Triage and Rapid Transport, or START. And basically this system works on three categories: RPMs. R stands for respiration, P perfusion, M mental status. So basically with this system, the first EMT who starts triage says, hey, if you can hear me, please walk to my voice. Anybody who can get up and walk to that voice is tagged green, whether you're using a tape or a triage tag, and they are moved out of the way. So now we know the patients who are left at the scene are those who are injured and not able to walk. So the next thing we check is respirations, yes or no. If they're not breathing, we position the airway, look, listen, and feel. If they don't start breathing, we can reposition that airway again and look, listen, and feel for breathing. If they don't start breathing, we black tag them. They're deceased, we move on to the next patient. If after we reposition the head, they start breathing, we tag them red, which makes them an immediate priority, and then we can move on to our next patient. If the patient is breathing, the next thing we want to check is their respiratory rate faster than normal? If they're tachypneic over a rate of 30 per minute, we red tag them. It means they're hemodynamically unstable. Otherwise, if the respiratory rate is within normal range, next we're going to check perfusion. Now we can use two different ways to check for perfusion. We can use capillary refill, which is identified as the Blanche test here. And if capillary refill is delayed over 2 seconds, we red tag them immediate. If capillary refill is within normal range, then we're going to move to the next parameter. If it's a cold morning, we know capillary refill is going to be delayed in everybody. So what we need to check instead is the presence or absence of a radial pulse. So if their radial pulse is not present, they are hemodynamically unstable, they're in shock, we're going to go ahead and red tag them. If they have a present radial pulse, then we move on to the next category, which is mental status. And basically, can they follow simple commands, yes or no? If they cannot follow simple commands, we red tag them. They have an altered mental status. They are probably hemodynamically unstable. They get red tagged for immediate. If they are able to follow simple commands, we yellow tag them as delayed, and we move on to our next patient. So that is the START triage method. Now the jump start triage is for pediatric patients aged 8 or less. Again, it builds on the basic categories of the START triage system. Are they able to walk? Yes, get them out of the way, and they will go to a secondary triage later on. Next thing we check is spontaneous breathing. If not, what we do is we reposition that airway. If they start breathing, we red tag them and move on. If they do not start breathing, we go ahead and check for a palpable pulse. If there's no pulse, we need to black tag the patient. If there is a palpable pulse, we can give 5 rescue breaths with a bag mask and reassess them again. If they are not breathing at this point, they're black tagged. Otherwise, if they do start breathing, we're going to go ahead and red tag them as immediate. The next category is checking that respiratory rate. Is it within a normal range? If the respiratory rate is less than 15 or greater than 5, we want to red tag them. It means that they're in shock. The next category goes down to palpable pulse. Do they have a palpable brachial pulse? Yes or no? If they do not have a palpable brachial pulse, then we tag them as immediate and move on to the next patient. If they do have a pulse, then we're going to do a quick neurological assessment. Okay, if they're able to talk to us, we can use the mental status assessment like in START. And if not, if it's an infant or a toddler, we're going to look for appropriate or inappropriate behavior. So if they are showing inappropriate behavior such as posturing or they're unresponsive, they get a red tag. Otherwise, we can go ahead and we can tag them yellow as delayed. So that is the jump start triage system for pediatrics age 8 and less. We see the SALT triage system, and again, SALT stands for sort, assess, life-saving interventions, and treatment or transport. So there's basically two steps. Number one is the sorting step, where we're going to move patients based on their ability to ambulate or ability to wave or make purposeful movements. And then we're going to assess them based on those who have obvious life threats and are not able to wave or move or ambulate or make purposeful movements. So a couple of benefits of the SALT triage system is that it allows us to apply life-saving interventions early on in the triage process. It's developed as a national all-hazards mass casualty triage approach to patients. So this means it's good for pediatrics, geriatrics, and adults. It's also designed to allow agencies to easily incorporate it into the current mass casualty triage protocol that they have in place, regardless of what kind of tags, priority identification they're using, etc. So the first step is global sorting. We're going to sort the patients based on who can walk. So we're going to say, if you can hear my voice, please come towards me. Again, we're going to move these patients to a designated area. Think about things like requesting a school bus or one of your local county transportation buses, where you can put these patients with an EMT so that they can be monitored in case somebody gets sick or their priority changes. But this gets them out of the way, so now that we know the patients who are remaining on scene are those who need treatment of some sort. Okay. So next we ask those who are on scene and did not ambulate from the scene, we ask them to wave or follow a command or make some form of a purposeful movement. Okay. Those who do not move, those are the ones we're going to go to first and start our assessment process. Those who are conscious and able to follow commands or make purposeful movements, those are the ones that will be evaluated after we've taken care of those who are not able to move or who are unresponsive. Next, with the assessment, we kind of get to put assessment and life-saving interventions, or LSI, completed together at this point, because now we're going to those who are not able to make purposeful movements or who are unresponsive, unable to move for whatever reason. Okay, so once we get there, we can start our assessment process, and we can also perform our life-saving interventions. Okay, so what we do first is we're going to look at, are they breathing, yes or no. If they're not breathing, they get black tagged, they're deceased, and we move on to the next patient. If they are breathing, we want to look at a couple of things, such as, are they able to obey simple commands, make purposeful movements? Okay. If not, do they have a peripheral pulse? Or are they in respiratory distress? Is there any major hemorrhage that needs to be controlled? Okay. If we need to intervene with life-saving interventions, we can do that at this point. If not, we can go ahead and prioritize the patient at this point. So if the patient is able to obey simple commands, has a peripheral pulse, is not in respiratory distress, and their major hemorrhage is controlled, then we can go ahead and look at minor injuries, yes or no. If they're yes, we can green tag them. If no, we make them yellow tag for delayed. Okay, and those who are not able to do those things, make the purposeful movement, they don't have a peripheral pulse, etc. Now what we're going to do is look at them to see what life-saving interventions can we provide, do we need to provide, and then we can red tag them, or we can tag them as expected, meaning that without additional resources, they will die because of the injuries they've sustained. So during life-saving interventions, the things that we're looking at are things like controlling major hemorrhage. We can put a tourniquet on somebody to stop that from happening, to keep them from bleeding out. Opening the airway, providing rescue breaths for our pediatric patients. Okay, if somebody has a tension pneumothorax and a paramedic is available, they can do a chest decompression. So after we've sorted our patients and we've done our life-saving interventions, treatment and transport is going to be based on the assessments and interventions and the priority that we tagged our patients: immediate, red, delayed, yellow, minimal, green, and expectant, which may be either gray or black, depending upon the type of triage colored system that your agency may have. And again, I just want to mention that anybody who's black tagged that is deceased is left on scene where they were found for investigation purposes. What we see here is the South Carolina Clinical Operating Guideline for Triage. These were released in 2025, and you can see that South Carolina has adopted the basic SALT triage treatment responsibilities. As patients are triaged and we get more resources on scene, firefighters, law enforcement, etc., patients should be moved red tags into the red area so that they can receive immediate treatment, because these are the sickest of the sickest patients. Okay, in the treatment areas, as we can see in this image, they are sorted by priority, and the treatment is going to happen first in the red triage area, the immediate, and then move over to the yellow, which are minor or delayed, and then into the green area, which are those with very minor injuries who are ambulatory. Okay? Patients are going to be stabilized for transport, and then they're going to be moved over to the transport area, again based on their triage priority, so that they can be transported to an appropriate facility by the most appropriate means available. Now, this may be ground transport via ambulance, and this may be air medical transport using helicopters. Okay, so the transport supervisor is going to be responsible for tracking patient information, maintaining communication with receiving hospitals, because we have to make sure we're not overloading any particular facilities. Okay, so the most critical patients are going to the closer hospitals, and the more stable patients will be sent to receiving facilities that are further out and would be able to do better for the longer transport. And the goal is to prevent overcrowding at any single facility, but to also ensure efficient use of all available healthcare resources. So here we see additional resources that were used in addition to your textbook to create this learning module. The first one is done by the U.S. Department of Health and Human Services, and it goes into a little bit more detail about the START and Jumpstart triage system. The second resource is the National Disaster Life Support Foundation's online SALT triage program. This is a great program. It takes a couple of hours to complete. It's done completely online, and again, you'll receive a certificate of completion for this. So please, at your convenience, take a look at these. Especially taking the SALT one would be a great review for you, and it'll count towards your continuing education once you get out in the field and you're working as a credentialed provider. So this brings us to the end of this presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, please consider going back to review any content that you might have struggled with. Thank you for watching the module, and I hope you have a great day.